So I'll be talking about managing a glaucoma suspect as an evidence-based algorithm. We know some of these suspects may progress to glaucoma, but right now we are only concerned about suspects and whether we need to treat these suspects at any stage. What defines the treatment of these suspects is the risk of progression. We need to know whether there is a risk of progression for that suspect. Now, risk can be quantified. If you look at a 65-year-old male, IOP of 34 and 23, angle closure, one eye has an advanced glaucoma, other eye's disc is healthy. He has a certain risk of progression in the left eye. Look at a 44-year-old male, IOP is only 22, open angles, suspicious looking optic disc, but very strong family history. So he has probably a risk which is a little lesser than the first one. Look at a 50-year-old male, IOP is only 25, IOP is higher, open angles, healthy rims, no family history, no risk factors. That will have a lower risk. So you have to quantify the risk among these different subgroup of patients to find out what is the amount of risk for each of them. A lot of speakers have spoken about all these risk factors, and when we collate all of them, we need to take an informed decision, treat or not to treat. That's the decision that we need to take. There are three options before a clinician. Now, we can treat if the progression occurs. So that is the number one. We'll treat only if the progression occurs, so that's the first step. The number two is we'll treat only if the risk of progression is very, very high. So there is a certain risk of progression. And we find that certain risk is high, or the damage is likely with the current intraocular pressures, or the risk factors overwhelmingly favor a treatment. We will treat it because of the risk. The third is that we treat everybody, that we take all the suspects and we need to treat it. So we'll not go into the third one. We are deciding between the first and the second ones. We also have to quantify the cost of therapy to the quality of the life. That's what we are talking about the patient. But there are two other factors, the patient's own fear of going blind and the physician's desire. We also don't want to harm the patient. So all these factors have to be combined to come up to a conclusion whether we want to treat the patient or not. The risk can be defined. It could be 5%, 10%, 20% over a period of a few years, 4 years or 5 years. But for the patient that's sitting in front of you, you don't know that risk. If you are not treating, because there is no disease at all, there are no visual field defects at all, why do you want to treat? So you need to take a balance between treating and not treating. I'll come to specific examples. Take about angle closure suspects. We know that the angles are appositionally closed in around 180 degrees. The pressures are normal at this point. There are no disc and field changes. So everything appears to be normal. There's a little amount of angle closure there. So what is the risk? The risk when we are thinking about is a conversion to a primary angle closure or angle closure glaucoma. That's the presence of synechias or raised intraocular pressure. And they indicate the risk is that indicated, and the risk of a progressive disease outweigh the risk and side effects of treatment. So should we treat it? What is the risk that it converts? We don't want to treat all PSCs. The problem here is that there's a large number of angle closure disease patients. If you look at, it's around 27.66 million. And PSCs, the top one, constitutes a majority of these subjects. It is nearly the population of Delhi. So if you look, do we need to treat everybody? We can't treat everybody. The resources are going to be overwhelmingly stretched if we start treating every PSCs. What is the risk of progression? The study by Ravi Thomas et al. Found that around 22% patients progressed to primary angle closure, but none of them developed an angle closure attack, and none of them developed a PSCG, and there were no biometric risk factors that were identified. So laser array.me for every subject with PSCs is questionable. We should not be treating everybody probably. Because of the large affected population and the low risk of progression, we don't know the natural history, the evidence, and the budget also is not there. The PI for PSCs remains a prophylactic procedure, and it is justified with a careful patient selection where we want to do it, and becomes a no for everybody. Decide, family history of angle closure, yes. A fellow eye of acute angle closure, yes. There are some retinal issues, patient requires frequent dilatation, yes. Follow-up is probably not possible. Probably at that situation also you can decide. And you find certain risk factors that there is a very, very patchy sort of pigmentation of the angle, as you can see in the picture, that possibly, yes, we can decide for a laser array.me at that point. If you are deciding not to treat, document and follow-up. Follow-up is very, very important. Document the angles, especially for any synechias, measure the intraocular pressure, explain the follow-up, ensure that the patient comes regularly to you. You can decide 6 monthly to an yearly follow-up, and then decide at what stage you need to treat. Coming to ocular hypertension, we have already discussed a part of it. But supposing there is a pressures 23, 25 open angles, the OHTS has already been discussed. I'm not going to the details, but basically it divided patients with the pressures of 24 to 32 into two groups, a medication group and an observation group. Observation group had no treatment. The medication group had a certain amount of treatment to lower the intraocular pressures. And the final point that we were discussing is the conversion to POAG, or open angle glaucoma. Now we know that some of the speakers have told that there is a certain amount of risk if we don't treat. So that is, the risk is around 9.5%, and the risk for conversion falls to around 4.4% if we are trying to treat it. So definitely over a period of 4 or 5 years, we can see that there is the risk is reduced with treatment. So to treat, because early treatment can reduce the conversion of POAG, we can be very justified to do it, but do we need to treat everybody? Go to no treat, 90% in both the groups, even if you're treating or you're not treating, 90% of them actually do not convert. So why do we need to treat everybody? We don't need to treat everybody. Or we need to define a certain factors that we treat somebody at risk. Also need to factor the cost of treatment, and we also know that there is no correct formula to correct for IOP for CCT in these situations, as speakers have told. If you look into the left side of the picture and the up, I can see that as the central corneal thickness is on the lower side and the intraocular pressures are on the higher side, you can see the highest risk of conversion in the OHTS. If you look closely, there is something called as a number needed to treat. What they found out is that if you treat everybody, for every 20 patients, 20 cases of ocular hypertension that are treated for 5 years, we can prevent 1 case of progression if we treat everybody. So we don't need to treat everybody to get that 1% out of the 20. So there were certain factors that were identified to find out the risk for progression that have already been discussed, including age, high intraocular pressure, thinner central cornea, larger vertical cup-to-disc ratio, and a higher PSD. The European glaucoma prevention study also randomized the patients to dorzolamide or no treatment. The NNT with this was 1 case of progression as compared to 143. So we don't need to treat everybody. But here, the higher intraocular pressure at baseline in both the groups was associated with progression. So finally, how do we take it to our patient? Practically, if you find that intraocular pressures are very, very high, certain situations, all the risk factors remain the same, and the intraocular pressures are very high, overwhelmingly high beyond 30, then you find that possibly there is a risk for progression, and possibly we need to treat. And pressures are not very high, 23, 24, possibly we can observe. That's somewhere in between that we need to take the risk and benefit assessment, whether we need to treat or follow up that patient very, very closely. Compare this, the risk factors, to that, the other one, the benefit to the patient. Because of the low incidence for glaucoma, the age and the life expectancy, whether treatment is actually benefiting the patient and the burden of therapy, to take a final decision whether we need to treat that ocular hypertensive or not. There's a certain amount of risk calculators available in the market that will give you certain amount of risk over a period of few years. What's the amount of risk? As somewhere around 10% we can see there. Now, they are basically used because we as ophthalmologists tend to underestimate the risk. If you have a patient sitting in front of you, you'll say that possibly the risk is less. But when you calculate it with these calculators, the risk is actually much more higher as compared to what you clinically estimate them. But the caveat here is that the subject should be very similar to the OHTS inclusion-exclusion criteria to these studies. That is sometimes not possible with the patient sitting in front of you. May work for many people, but for that individual patient, you're not very sure that calculator is actually working or is giving you some information, the patient is converting or not, we are not sure about it at that point. So not every patient with ocular hypertension should be treated. Determine an individual risk for progression. We find out all these factors that have been discussed. Look at all those risk factors, vein occlusion, disc hemorrhage, myopia, age that have been discussed, and then decide whether we need to treat that patient or follow up that patient. A suspicious looking optic disc. I'd take at this point that there's possibly no visual field defects at this point. Now, there may be some amount of physiological cupping, anomalous disc, everything else is normal. But they are very, very unlikely to be associated with a very high intraocular pressures or progression. So these are very sort of physiological or abnormal sort of discs that we have seen that Saiba has also shown. Have a baseline documentation. You can include a disc photographs for that. Okay, you can have a baseline visual fields also that will show some defects, but they're not likely to progress, and have a careful follow-up with them. Don't treat. A suspicious looking optic disc with a cup-disc ratio of around 0.7, then intraocular pressure is recorded as 22 with applanation. The visual fields have been done. The ophthalmologist has noted that everything is outside normal limits. The test is done reliably, and pattern deviation is present, and he decided to treat. And you can see that the medication has to be given. But look at all those factors and then decide whether you actually need to treat that patient or not. Just a physiological problem with a little borderline pressures. So don't base a diagnosis and therapy based on results of a single test. Look at the disc, look at the visual fields, look at the OCT, look at the family history, look at other risk factors, keep the red and green disease that Mona has described, have a step ladder approach to treatment, keeping all these factors, and then decide whether we need to treat that patient or follow up that patient. A single test is not going to define whether we need to treat them or not. So in a patient whom the probability or the prior probability of having glaucoma as measured by clinical examination is low, The imaging studies alone are unlikely to lead to the diagnosis of glaucoma. No test has been shown to be superior to qualitative evaluation of the optic disc photographs. So be very careful. Optic disc photographs are very, very important, especially in case of suspects. We can use, as Mona has discussed, about the OCT for predicting a progression in a subset of these suspects. But the optic disc photographs are very important. Take an example. Now, this was a young boy, around 26-year-old male, had a trauma in the right eye around 10 years back, has an angle recession in the right eye, and you can see the nerve fiber layer defects. Pressures are around 17 and 16, central corneal thickness is normal. If you look at the OCT, there is a certain amount of defects that you can see. The visual fields are showing a little amount of scatter, but I don't feel that this patient requires a treatment. He requires a closer follow-up. I'll call him first time he had come at 6 months, and probably I need to follow it up over a period of time. I will not like to treat this patient, despite some evidence that he has a glaucoma in the right eye that is probably in the past. The last thing is the risk factors. Look at the family history. If you have no other abnormality after a comprehensive examination, do a disc photographs, have an annual check, look at other factors that Maya has discussed, look especially at the look of steroids. Now, we should be humble that we still don't know the full effects of intraocular pressure and its fluctuation on the human eye. Finally, do no harm. Decide whether treatment is of benefit to the patient. Keep in mind the life expectancy and the comorbidities, and that is with a reasonable certainty. Without use of anticipated treatment, the patient is likely to get worse, then only treat. Now, treat if the optic nerve, I'm sorry for the spelling, the optic nerve deterioration is evident. There are subtle optic disc and retinal nerve fiber abnormalities that are identified over a period of time. You see new visual field defects, or the patient has a very high intraocular pressure and nerve damage is expected. That these are options that we need to take if we are to start thinking about doing a treatment. From the place from where I come, this is a rural truth. The distance to pharmacy is very, very important. People travel for long hours, half days to get that bottle of Timolol. So 9% travel more than 2 hours, 29% more than 10 kilometers. Some of my patients travel half of the day to get that bottle of Timolol from the hospital. The availability of drugs is very important. Decide whether you actually need to treat or not, or you're trying to just give a bottle to the patient and finish off. And if treatment is suggested, minimal IOP lowering therapy, especially PG analogs. Please don't base any glaucoma surgery based on suspicion alone. Have a close monitoring with structural and or functional testing depending on the risk profile for the patient. If it's a low risk, probably an yearly follow-up, or if moderately to high risk, probably a little earlier, 6 months could be done. Thank you.
Thank you, Dr. Panday, for nicely giving us guidelines, very comprehensive guidelines for